All right, good morning, everyone. I think on the interest of time, I have 11:30 on the dot Central Time. We're going to go ahead and get started. Welcome to the first webinar in our series of tobacco interventions for individuals with substance use disorders. Today's webinar will focus on the rationale of addressing tobacco addiction within addiction services, provide a description of an integrated recovery-oriented model, and share an overview of the rest of the webinar series. My name is Janelle Koshinsky with the American Lung Association in Minnesota. This webinar, subsequent webinars, and technical assistance calls are all part of the American Lung Association's commitment to decrease tobacco's significant and disproportionate impact on people with mental illness or chemical dependence. I'd like to now introduce our presenter for today and throughout the rest of the series, Tony Klein. Tony Klein has a Master's of Public Administration degree with a concentration in healthcare management and holds numerous credentials in substance abuse counseling and training. With over 30 years of administrative, clinical, and training experience, he is known for his work as an advocate for addressing tobacco dependence in addiction services and the development of a tobacco intervention model that utilizes evidence-based practice guidelines anchored in 12-step teachings and therapeutic community principles. Mr. Klein served as a member of the New York State Partnership for the Treatment and Prevention of Tobacco Dependence, the work group that consults New York State's Office of Alcoholism and Substance Abuse Services on drafting Regulation 856, requiring 1,500 New York State certified substance abuse providers to develop tobacco-free services. Mr. Klein has coordinated the establishment of a continuum of tobacco interventions linking inpatient and outpatient treatment and has served as a principal investigator for a 3-year study to elevate a systems approach for tobacco-free residential services. He provides consultation, training, and technical assistance to community providers, municipalities, and state agencies. In addition, Mr. Klein serves as manager of outpatient services, Rochester Regional Health, Unity Chemical Dependency, and Brighton, New York. The American Lung Association has brought Mr. Klein to statewide conferences and has appreciated his insight about the relationship between tobacco and other addictions. We are happy you can join us today. I'd now like to welcome Tony Klein.
Thank you, Janelle. Can you hear me okay?
We can.
Okay, super. Good morning, everyone. I'd like to begin by first expressing my appreciation to the American Lung Association of the Upper Midwest for sponsoring this series. I'm looking forward to it. I hope that many of you will find it helpful. The training strategy is to provide relevant information on addressing tobacco in addiction services, along with recommendations for practical application. So we're going to make this somewhat interactive, as Janelle suggested, by means of a combination of webinar presentation and technical assistance conference calls, where everyone will have an opportunity to provide feedback, share some experiences, and be provided additional information. This is an overview of the series. It's progressive by design, so I highly encourage that you participate in each scheduled event and sequence, especially with regard to the first 3 webinar presentations and related conference calls. Today, webinar 1 will speak to the rationale for addressing tobacco. I'm going to describe an integrated recovery-oriented model, where we provide tobacco interventions within a framework of lifestyle change consistent with the message of overall drug recovery. On March 28th, in a couple of weeks, we'll devote our time to identify client engagement strategies. Tobacco awareness promotes cognitive change, not behavioral change. So I'll offer instruction in how to facilitate discussion on tobacco that enhances clients' interest in the topic, advances stage readiness, challenges some traditional social norms that may sustain tobacco use. I'm going to be very specific in describing counseling methods and clinical objectives at that time, and we'll ask you to try them out. So you'll have everything you need to facilitate a tobacco awareness session. A couple of weeks later, on April 11th, we then can have our first technical assistance conference call to talk about the experiences of trying out the tobacco awareness intervention. On the third webinar, April 18th, we'll speak to tobacco recovery, which is now behavioral change. So this is the practical counseling skills to help our clients establish and maintain tobacco abstinence. Again, we'll follow up on May 2nd with a conference call to provide feedback on that intervention. Two more webinars in May. I thought it would be good to have one specific to co-occurring disorders, as well as speak to providing treatment strategies for those who are HIV infected. And vaping is so big these days, electronic cigarettes. So I thought it would be good also to spend some time talking about these alternative nicotine delivery devices and make sure that we're current on our understanding of what's happening there. The last contact in the series will be on June 6th, which again is a conference call where we can just summarize everything that we discussed and sort of wrap up the whole process. So let's begin. Today's discussion, tobacco use specific to individuals with substance use disorder. There are certain aspects of how those who have co-occurring mental illness as well as addictions use tobacco that is different than the general population. So we want to highlight some of that today. As we said, the rationale for addressing tobacco, some of the practice guidelines, and the rewards, the benefits of addressing tobacco. We have specific learning objectives today. Participants will be able to describe the neurobiological and behavioral association of tobacco use to other drugs of addiction, identify how addressing tobacco improves treatment outcomes and overall drug recovery, and then cite 3 barriers and solutions to effectively integrate tobacco interventions into existing programming. Now, I assume most people on this call realize that our clinical population has a much higher prevalence of tobacco use than in general. Their prevalence rates by diagnostic category across studies reported by Dr. Morris. It's interesting to note that there appears to be an association between the prevalence of tobacco use and the severity of one's primary diagnosis. We see this by looking at different levels of care in addiction services. In our outpatient clinics, for example, we have found that approximately 60% of the folks that walk in the door are tobacco dependent, while in higher levels of care, residential, inpatient settings, we find a higher prevalence of tobacco use. So it's typically around 75 or 80%. Nearly half of all the cigarettes in the U.S. are consumed by individuals with an addiction or mental illness, accounting for, actually it's over 40% of the domestic cigarette market. Pretty scary stuff. And of course, this all results in significant morbidity and mortality. Almost half of the cigarette-related deaths every year are among people with mental illness or substance use disorder. There was a landmark study in the mid-90s that Richard Hurt published, which was an eye-opener for many of us, that acknowledged that alcoholics who embraced sobriety, the cause of death was tobacco, not alcohol. And there were subsequent studies as well to indicate the harm with regard to tobacco use for those that we serve in our program. So let's take a look at this more closely from a biopsychosocial definition. We believe that there are comorbidity factors, due to the comorbidity factors, a greater vulnerability to tobacco use disorder and the severity of one's disorder among those with addiction and mental illness. Zadonis and Williams and others have published some great information on this, looking at factors associated in tobacco use with those with mental illness and or substance use disorder. So there's biologic and pharmacologic factors, various psychological and behavioral factors that we need to acknowledge and we'll be talking about today, as well as many environmental, some of the social norms and different cultural factors that contribute to what we know about this. Now, the first point that we need to acknowledge as we look into this is that the product, the cigarette, has been designed to promote addiction. Not intoxication, but reinforcement. There is significant evidence within industry documents dating back to the 1970s. Let me get this next slide going here. To indicate that tobacco, the industry actually studied the drug culture. They were looking to see why that guy who keeps getting arrested for drinking and driving continues to drink and drive. Why is that woman who goes to those dangerous neighborhoods and engages in high-risk behavior to cop her next bag of dope? What promotes that kind of thinking and behavior? Well, they studied that and applied what they learned in terms of reformulating cigarettes to the point now where the cigarette really is a highly sophisticated drug delivery device that has been re-engineered to hijack the brain into addiction. The length of the cigarette, the length of the filter, the way the filter is ventilated, the ratio between reconstituted tobacco and some of the treated tobacco, which is enhanced with chemicals to promote a more faster acting response of nicotine to neurochemistry. All of this promotes changes within our neurochemistry to promote, again, the reinforcement. So the impact to neurochemistry includes some stimulation. It promotes some calming effect. Again, the dopamine reward system is impacted for reinforcement. There's also some analgesic effect that we know with regard to how this influences neurochemistry. Eric Kandel and his colleagues at Columbia University demonstrated that chronic tobacco use promotes neuroplastic changes that primes the brain for an addiction. There's a really good YouTube video that I would recommend that you may use in client education. It's entitled Nicotine Priming Addiction Pathways, in which it's a nice short little clip in which he explains how the neurochemistry is influenced. The research they did was primarily looking at how it enhances the properties of cocaine. If I'm addicted to cocaine and I'm chain smoking cigarettes as part of my drug use ritual, which is very common, the cigarette is woven into that ritual of getting high. My addiction is not to cocaine. My addiction is to the synergistic effect of how the cocaine and the tobacco smoke promote changes to my brain chemistry to reinforce the addiction. So if I stop my cocaine use, the consequence of that cocaine use will leave me, but if I continue with the tobacco use, that pilot light to the furnace of my addiction is still very much lit. There are neurobiological bases for why it's important to modify tobacco use in drug rehabilitation process. So the cycle of addiction is reinforcing and progressive. We begin because it does help regulate mood. We are in a position of a very rapid tolerance, and again, it has a short half-life. The result is that people will smoke a lot to eliminate withdrawal feelings. What happens as we get into the cycle of this, though, is that the motivation to smoke is really not necessarily pleasure, but getting rid of the discomfort of not having the cigarette. So it's really basically just craving and eliminating the craving that occurs from not using it for a while. The handling, in essence, smokers self-medicate with mood-regulating nicotine is what I'm suggesting. And what's very interesting in our population is that the intensity of how one draws on the cigarette, the frequency of hand-to-mouth motion, does greatly vary. If you watch someone who uses tobacco who has a history of smoking marijuana, they don't smoke the cigarette, they hit on the cigarette. You know, the way they hold the smoke in their lungs, you'll see the behavior that it would be common with using other substances and how we relate it to how the tobacco is actually used. Now, think about that in terms of reinforcement, because if, let's do some math here, if a pack a day, which would be 20 cigarettes, say that you draw 10 puffs on each cigarette, and we do that throughout the course of a year. If you multiply that up, it's 73,000 hits of nicotine to the brain. So how one is using the cigarette, how we're self-medicating with it, the frequency of how we're dosing our behavior, you know, how it's tied into our setting and our behavior is very, very significant. As a drug counselor, this is concerning to me because in relapse prevention work, we talk about changing people, places, and things. And so what are the triggers and the behavioral cues that are associated to my tobacco use or my drug use? And so often we will find that the cigarette can be a very significant player woven into that fabric of the drug use. Now, what I find most interesting as we move forward with that is the psychological and behavioral factors. Tobacco use maintains drug use rituals and beliefs. I got to have something. It's that self-medicating kind of mentality. I've done work in residential care developing tobacco-free programming, and one of the things that we learned is that there's always underground activity of selling loosies, untaxed cigarettes, within the facility. And we discovered that the folks that are selling them were the folks that were drug dealing out on the street. So they were maintaining their self-worth by their skill sets of being a drug dealer by bringing it into the treatment facility. Again, we would confront that in counseling because that would, in our view, be an interference with the identity change and lifestyle change that one needs to facilitate in order to embrace recovery. So the use of tobacco maintains parallel behaviors that is associated to someone who is in active addiction. Now, to illustrate this point, let me just share with you an example. Therapeutic community is a form of drug rehabilitation that's common in urban areas. The method of treatment is community, so it's socialization. Most of the folks in these programs are peer counselors that are helping one another in embracing recovery. There are very strict guidelines to live in the house, the rules. You have to be drug-free. You have to embrace what's called the principles of right living, where you're staying away from criminal activity. You're in a position of advancing your education or seeking a job. You're, again, learning the socialization aspect of being in that type of environment. These are very supportive and very beautiful places. Sometimes, the feeling of recovery, the spirit of recovery, if you will, it's like a warm blanket on a cold day when you walk into this place. So they're families, and they address you as being a visitor to visiting the family. Well, I had a group invite me to attend a community meeting at this place called Odyssey House. It was in Harlem, and approximately 50 adult males, an all-male facility. And I went there and we generally discussed some information around tobacco. This is one of the counseling interventions that I'm going to talk about more. Tobacco awareness, again, is more of a group motivational interviewing strategy where you're just exploring what is the meaning of tobacco use. You ask open-ended questions and create teachable moments. And so that's when you can share some information or research. So we were looking to see how cigarettes were re-engineered to make them more addicting, how they're woven into drug use ritual, how, again, it can maintain the potential for sustaining some active addict thinking, feeling, and acting out. And I'm going to paraphrase some comments that I want to share with you of what someone said at the end of that meeting. What he suggested is, he said, I'm going to tell you why I need to address my tobacco. And he went on to say, do you know where I go when I'm done with dinner? He said, I'm walking out the front door in order to cop. And everybody's ears perked up, and he said, oh no, I'm not going to cop any dope. I'm going to cop a loosie, a cigarette. But he said, while I'm walking out that front door, I'm experiencing all the feelings that I experience before I get high. He said, I'm salivating. My heart's beating a little bit faster. I'm totally preoccupied with the thought of how wonderful drawing that smoke into my body is going to feel. And then he said, I walk over a couple of streets over. I'm putting myself in a high-risk area because that's the corner where I would cop my dope, but that's where his tobacco man was that he had a relationship with. He said, I'm getting real now. It's not legal to buy an untaxed cigarette from on the street from somebody, so I'm engaging in illegal activity. I buy that cigarette, I smoke it, and I'm not casually smoking that cigarette. I'm working it. I'm hitting on it heavy. I'm in a position where, I'm getting that little head rush, and I'm loving that feeling. And then he said, I walk back to this facility. I'm breaking the rules, so I can't tell anybody of what I'm doing. But think about how my cigarette smoking is impacting my recovery because of tobacco. I'm still in a position of looking forward to that little head rush. I'm still craving. I'm still experiencing the high before the high, if you will, the euphoria. I'm still manipulating the system. I'm still keeping secrets. He said, as long as I continue to use tobacco, I'm very close to my next bag of dope. And he identified this in a 12-step term of being a half measure to his recovery. In other words, he wasn't doing everything he could to embrace the lifestyle change of recovery. Now, this is an example of tobacco awareness, and it's the type of dialogue that we want to engage in our programming. This is where we're going to personalize it to the population that we serve that will promote interest and will advance stage readiness, change the culture overall in getting people to embrace the concept of addressing tobacco. So the paradox here is as one walks through a drug recovery process, the cigarette is often the last thread of a tangible link to the old identity, the person in active addiction. However, tobacco use provides a sense of familiar comfort. However, it inhibits growth to some of the key objectives of the lifestyle change, cognitive and behavioral change to redefine self and lifestyle, which is the recovery process. That's the message that we need to highlight as we're engaging our clients and talking about this. So addressing tobacco improves treatment outcomes. We know that it does not interfere with recovery. 20 years ago, we were worried, first things first, you should not address tobacco concurrently with other substances. We now know that it is a good idea to address it concurrently. It actually is easier to embrace recovery when you're dealing with all the substances that you're using. We also know the work from Prochaska, the meta-analysis, that the improvement that takes place. There's a 25% increased likelihood of long-term abstinence from alcohol and illicit drugs when we're eliminating those parallel behaviors, those associations that I'm describing here for you today. So the barriers to addressing tobacco our resource limitations, again, old traditional beliefs, other factors. Of course, if we have staff tobacco use, some of the defenses that are playing out to justify continued staff smoking can be projected onto our patients. But all of these issues with regard to barriers, education, current research findings to challenge the traditional beliefs, the message is that addressing tobacco improves treatment outcomes and overall recovery. Terry Rustin, a physician down in Houston who has a special interest in addressing tobacco and addiction services, used to share some interesting advice, which I want to pass on to you. To appeal to professionals, you need to share research. They want to see the data. So when we're talking about staff training, we have to have the evidence to support what we're saying. The more significant way of appealing and engaging our clients is not research, it's narratives, it's storytelling. It's the example of what I gave at Odyssey House, where you can generate a discussion where people are personalizing their experiences to tobacco and identifying the conflict to what they want to achieve in terms of recovery. So how we engage people and how we facilitate the discussions is how we're going to address these barriers. Now, it's important as we talk about this stuff, though, to make sure that it's a recovery-oriented message. And that speaks to the question of what is recovery. Recovery is much more than stopping the use of a substance. No one really quits things in life. We replace things. So as one learns healthy coping skills, it gives them the opportunity to let go of the unhealthy coping skills. This is a process of addiction, not subtraction. Now there's 4 domains that we've identified, SAMHSA did, in terms of the growth promoting learning experience that one can reach their full potential and the rewards with regard to physical, emotional, spiritual health, a stable home life. You have to have a purpose to get out of bed in the morning. You have to have a reason to embrace life in its fullest, and again have a social network where you have some emotional support. So recovery is growth promoting, and it is there's a expression of dry versus sober in Alcoholics Anonymous, and dry or dry drunk is basically someone who simply stops drinking but doesn't really learn the lifestyle of sobriety. Sobriety is where, again, you are embracing healthy coping skills and acknowledging the rewards to all these areas of one's life, and that helps to sustain and promote further sobriety. Well, just like there is a difference between dry versus sober, there's a difference between being a cigarette-deprived smoker and being in tobacco recovery. Tobacco recovery implies a very different process than smoking cessation. So as we embrace the different interventions and generate discussion, we want to make sure that we talk about this in this positive way of how we can improve our overall experience in drug treatment, remove some of the potential risk for relapse to drug of choice, and just find the rewards. We have to instill a sense of hope that this is a picture of how we're painting it overall. So there's 2 fundamental goals. We want to address this culture aspect, talk about it within a recovery model as we provide some treatment to help modify behavior. This should be written right into a treatment plan in terms of your day-at-a-time recovery process. So the cultural aspect of this, we can maintain fidelity to evidence-based practice by modifying the practice guidelines to be more effective within a particular culture. Now, I'm going to speak to this in depth in our next webinar, but I think you're catching on to what I'm suggesting here and how we have to approach this whole topic and utilize this recovery-oriented type of a model to make it effective. Having problems with my mouse. So now there are 2 interventions, specific behavioral interventions. Tobacco awareness, again, is the discussion. It's to develop interest. It's really more of cognitive change. Tobacco recovery is then a different process of where we're providing counseling to help establish and maintain abstinence. The counseling methods have a place with regard to stage readiness. So motivational interviewing is how we facilitate the tobacco awareness counseling, and that is used primarily to address those in a pre-contemplative or contemplative stage of change, whereas a more prescriptive CBT is used in preparation or action. So tobacco awareness facilitation involves motivational interviewing. Again, storytelling. You want to generate narratives that peer-to-peer dialogue can help explore the topic, and then create teachable moments where then you can provide education and share some information that would be important for our clients to help further their understanding of this. Assuming many of us have been trained in motivational interviewing, we'll talk a little bit more about this again in the next webinar, but this is the method that we would use in tobacco awareness. These are some suggested topics for facilitation, And again, in webinar 2, I'm going to in depth explain how to facilitate each one of these topics so that you can try it out. Tobacco recovery counseling then again is more of the skills training. The CBT again is still client-centric, and we want to include relapse prevention work, and I always encourage the use of pharmacotherapy. This is a components of a CBT program that Jennifer Gottlieb at Mass General developed about 10 years ago for a MICA program. It was very successful, and I really loved the way that she presented this. But you can see that there are very specific areas that need to be addressed as we plan out the change process and what we teach in that level. So I want to share with you a project that I worked on to demonstrate how actually utilizing some of what I'm talking about can then change the culture. And this was a program on Long Island called the Post-Addiction Treatment Center. It's an inpatient facility, 79 beds. Attached to the inpatient program is a community residential program of 21 beds. So many times patients will complete their inpatient stay and then be transferred right into the CR, the community residence program. Now, I wanted to explore, the project here was to identify how an integration of creating a dialogue around tobacco, as I'm talking about it today, can influence the attitudes of the population as a whole. How does it impact community? We can generate discussions and various components of care. How does it change the thinking or the social norms? Now, this is a graph that shows 5 weeks of the intervention. I was actually there for 8 weeks, and I developed this after 5 because I needed to report into my funder in our state capital of how this was going. But the method was that every Monday morning I met with the entire population within the inpatient unit. All the staff were present and were observing the session as well. The first week in awareness topics, you could see I was highlighting how tobacco is woven into drug use ritual, how it's associated to the use of other substances, and would a group decisional balancing exercise looking at the costs and benefits of maintaining the behavior versus stopping the behavior was the second week. Letting go of unhealthy relationships, so there's an emotional component to that arm's reach away 24/7 companion that's been with me and non-judgmental and saying goodbye to it. So, you know, what's that process like was our discussion of tobacco awareness on that day. We reviewed behavioral defenses and then repeated some understanding of how tobacco is woven into drug use ritual on week 5. The data that I'm showing you was based upon a survey. At the end of the session, we had a very brief, I think it was like 6 questions on the survey. And this question is, tobacco addiction should be treated in alcohol and drug programs. And this is just looking at the 2 extremes, none of the mid-range responses. But as you can see, week 1, 22% strongly agreed with that statement. After 5 weeks of having this kind of ongoing discussion, and I may add it wasn't just Monday morning, then this was carried into some of the group treatment throughout the course of the week and was maintained by staff. So after 5 weeks, the survey showed that we now had 46 people strongly agree to that. 45% strongly disagreed, and you can see again that changed to 30% after 5 weeks. Keep in mind that these were open-ended groups, so you didn't have the same population in the room, that there was a change of like 50% of people coming and going. Another question was, stopping tobacco use at the same time is a good idea, at the same time as other substances. Again, on week 1, only 16% strongly agreed to that. After talking this up for 5 weeks, we were at 38%. And again, there seemed to be a baseline with regard to those who strongly disagreed with that. A real important thing to look at would be changing social norms and understanding the value of pharmacotherapy. There's a lot of mythology around nicotine replacement therapy. And so that was a component of what we would talk about. As you can see, only 17% strongly agreed that it would be helpful, nearly half after making sure that that was fully communicated and reinforced over time, that people had started thinking about it very differently. So my point is that to integrate this isn't an adjunct to our treatment. We want to weave it into the components of care that we have in our existing programming. We can do this very helpful in a very simple fashion. The change strategies would be to anchor the rationale for addressing tobacco to the organization's mission, develop a alcohol, tobacco, and other drug policy. So this is not a tobacco-free policy or a no-smoking policy. It's a alcohol, tobacco. I don't have I run an outpatient clinic. I don't have a sign in my parking lot that says it's a heroin-free parking lot. I mean, we want to support recovery here, so we don't use any type of substances, and we identify all of them. So again, this integrated message is important, as well as then how we provide the interventions in our programming. Highlight the topic as a recovery issue, communicate it through your treatment philosophy. Strategically address any resistance to social change. So we want to develop surveys to see what stage readiness our colleagues are, the agency that we work with. Do we need to provide more research and data to secure buy-in to this, or do we need more to weigh in more in how-to, the practice guidelines? And so you want to make sure we're matching training needs to the stage readiness of the organization. We want to use language consistent with treatment and recovery culture, cultivate a consensus, and a big one would be sustainability. That as we develop our policies or procedures around this, make sure that we may use a QI process to have some indicators to measure how well we're doing and if we need improvements. The clinical supervision should be a component of how that is audited and monitored over time. So this is just a brief little graph to show how we might consider system changes. These are some typical components of care in an addiction program. Are we assessing for tobacco use disorder? Is it being documented in the chart? How is it communicated during an intake or orientation process? How is it shown in the treatment plan? You know, what is the problem statement? What is the goal, the objective, the method? How can we show that so that it becomes a living document part of how we're providing care? What are the program therapies? Do we have a routine of tobacco awareness education that everyone participates in? So we're keeping that topic alive, the dialogue going, and normalizing the fact that we're going to talk about tobacco as much as we talk about alcohol and heroin and marijuana and other substances, because it's part of our disease of chemical dependency. What are the psychoeducational presentations we'll be developing? How is this discussed during case review? Discharge planning. Does that person have access to NRT as they're moving from an inpatient level of care to an outpatient level of care? What is the plan to help establish and sustain tobacco abstinence? Think parallel process for clients and staff. The question always presents itself, what about the staff that use tobacco? And you know, we need to be very sensitive to that. This is not a smoker versus a non-smoker issue. This is a quality improvement initiative. I think a common denominator that we all have that work in this field is that we want to provide the best care possible. And if we have staff that use tobacco, you know, we need to address that by helping them to adjust and adapt to any of these policies that are being implemented so that they can support it. And you know, that may be a case by case on a very personal basis how to approach that. But to be respectful of one another and make sure that we're working as a clinical team for the same goal is something that has to be important in how we pursue the change strategies. This is a sign that I wanted to share with you just to demonstrate the language. And again, this is more supportive of autonomous motivation. It is recovery oriented. This was a community residence program where I helped develop some alcohol, tobacco, and drug-free policy. But you can see it's like pick up your mitt and join the ball game, folks. We need your help to support one another in recovery. This house is alcohol, tobacco, and drug-free. By not using these substances, we can support each other in recovery. So again, reinforcement of the message that has to be communicated in multiple ways through counseling and different means of messaging as a means of changing attitudes in the culture. So why an integrated recovery-oriented intervention? Well, it's consistent with our mission. It improves care, quality of overall recovery. Models of care in our programming is designed to treat substance use disorders. So there really isn't a whole lot more than we need to do. We just have to apply our model to include tobacco in this. If you have staff that are skilled in facilitating counseling on how to manage craving to alcohol or cocaine, they can apply those same skill sets to cigarette craving, or the other many relapse prevention strategies, or you talk about neurochemistry and all the stuff that we provide in terms of client education that is very typical in drug treatment. All you got to do is include tobacco in the discussion. It doesn't even have to be highlighted. Just don't leave it out. Make it part of the content of what we're talking about, and that will again make this so that it's a natural component to how it's integrated in that message. That will make a huge difference in having an understanding that this is something that needs to be a part of the treatment and the recovery process. Practitioners are highly competent in providing psychosocial treatments. We do this better than anyone else in any other area of healthcare. We have the most time, the intensity of our programs, the frequency of how often we see our clients is significant, because the more you communicate, the more we provide care, the more we provide counseling. There is a dose response to outcome. The more you dose the intervention, the better the outcome we're going to see. So this is a great opportunity, just by the nature of how our programs are designed, to be able to integrate these interventions and provide these services. We can maintain fidelity to evidence-based practice while tailoring our protocol to accommodate, again, the spirit of recovery, the cultural beliefs, the values, the attitudes, and behaviors of the targeted population. And again, of course, tobacco is a killer, so we want to do everything we can to save lives. Some of the founding fathers in the field, again, Bill W. and Dr. Bob, of course, both died from tobacco-related disease, and as did many others in our history. A couple of guidelines that I wanted to offer and recommend to you. Of course, we're all aware of the Public Health Service guidelines. The Psychiatric Nurses Association manual, I believe you can get this online, was a nurse-delivered tobacco intervention in a co-occurring program that was in Rochester. And Dr. Sharp and her colleagues did a great job, and this is actually a workbook manual where there's actually various forms to, documents where you can actually measure how well your patients are doing and how you dose NRT, and so it's a very useful guide that I would suggest that you might check out. And there is this is something we developed in New York State when we developed our regulations mandating tobacco-free services. And so if you go online, you'll find the information that'll be online training for a lot of what I'm speaking today. And some of the topics that we're going to be talking about in this overall series. So I think I can open this up to questions. And Janelle, Reba, how can we move forward with that?
Thank you very much, Tony, for all that you shared. A lot of information and ideas to follow up. There are a couple other questions. One was regarding New York having this requirement for tobacco-free services. Can you give a sense of kind of where we're at as a behavioral health professionals in our nation, in terms of, are there other states that have those requirements, and kind of what do you see happening in this movement over the next few years?
Well, that's a great question. I think that there is a lot of discussion around this in different regions of the country. There's I call it the recovery movement, where we're actually looking at treatment and recovery, I think, in very different ways than we have in the past. A lot of what I talked about today, again, was this holistic approach where we're looking at all of these domains. I think that supports the tobacco component to addressing this in treatment, where there is research. Attitudes have changed. People are, this is not 1950 anymore. We know that this is something that has to be looked at, and it's just a question of how do we do it. So I think in a general way, most people support the idea around it, but to what degree, how does it fit into programming? How do we implement it? And what I'm trying to talk about today, again, is this integrated model, which I think is the easiest way of pursuing it. So I think that there is an interest in this. One of the lessons that we've learned in New York by doing this is that the sustainability component to it. So I did statewide training here. I know a lot of our providers, many of whom did a wonderful job in developing our tobacco interventions and creating alcohol, tobacco, and drug-free policy. Some of them are still doing well with it, and some of them are not. And the reason is that they didn't really have a means of sustaining the interventions. Staff turnover, leadership turnover, different policy changes where the champions, so to speak, that were leading the charge are not necessarily in the picture anymore. So I think to do this in a more systems approach, where you actually have a protocol that becomes fundamental to your policies and procedures, and then you have a method of maintaining it, is where it really works well. The attitudes toward this has changed. When I first started doing this in the late 1980s, people would be very angry at what I was saying, because in those days we didn't believe that you should address tobacco, that no major changes in the first 12 months of recovery, and that included don't mess with the cigarettes. And so when I started talking this up, as I was looking into the research and questioning our approach to this, a lot of people were not happy with having these discussions. And so we've learned a lot over the years. I think society has changed overall. There has been great media attention and research that supports what we're talking about today as addressing it in behavioral health services. The folks coming into the field now, the new therapists, can't imagine not addressing tobacco. In what I see in our clinics, we have folks just out of their master's program, and it's like, you mean people would smoke in treatment? That just doesn't make any sense. So I think that there is a real evolution, so to speak, in terms of how our attitudes have changed over the years. And to continue that it's happening, and it's happening in different intensity or different degrees in different parts of the country. Again, this webinar that we're doing, and how we can apply to whatever degree we can, what I'm talking about within your own program is going to be beneficial. So I'm hoping I'm answering your question. As far as data with what's going on in different areas, I'm really not clear on that. It's changing, in different ways, I guess.
Mm-hmm. So in terms of one of the key sustainability issues that you raise with staff turnover, do you have recommendations for how to onboard new staff?
Well, yeah, it's part of training and clinical supervision. So you have clinical standards that have to include addressing tobacco within those standards. And that's why I'm saying that if this is woven into the clinical documentation, if it's shown in the patient chart in the diagnosis, then we're obligated to do something with it in the treatment plan, is the way that we talk about providing care. So then how do you write it in the treatment plan? And then what are the treatment therapies, the interventions that are going to support how we're approaching this? So this whole systems approach, starting from how we intake someone into our program and then how we then carry this through the whole treatment experience, that has to be monitored and audited through clinical supervision. And then people will automatically do it. We started identifying in our case review stage readiness for behavioral change, and it includes tobacco as well as other substances. And it's just a natural process now that people will talk about what stage of readiness one is in to address tobacco, and therefore these are the interventions that we're going to show as the methods to support some clinical objectives in the treatment plan. So to have it woven into, again, the service in that fashion is what will sustain it. What the opposite to that would be to have an adjunct to treatment. Okay, so we have our drug treatment program here, but if you want to stop smoking, go down the hall and knock on that door, and there's somebody else that will provide smoking cessation for you. That's what we discovered does not work and is not sustainable, because there's no motivation that is going to, I shouldn't say no motivation, but the intent, the degree of motivation to do that is going to be less, because you're now competing with the bench out in front of the facility where everybody in your group is going to smoke before and after their treatment. So you're not going to compete with that. If we integrate this into the program, make sure that it's reinforced in our message of recovery, and then have this as the natural components of care in everything we do, that changes the culture. We've got to address the denormalizing tobacco in the culture if we're going to have high utilization of services to stop smoking. And so I hope I'm answering your question, but that's what that's the spirit of this. That's the way that we need to talk about it with new folks coming into the field and working in our programs.
Great. So another question that goes back to the mention of staff who are tobacco users. Can you give an example of yourself as a manager, how you would approach staff who smoke, particularly as an agency would be looking at implementing new tobacco measures or standards?
Yeah, that's a great question. I think, again, the clinical teams typically are fairly close, that, in terms of on a relationship basis. And so you have to appeal to someone on a very human-to-human basis. And people will understand that, you got to create the vision. And from a leader, we have to start out with recognizing that this is part of our mission. We're doing this to improve our quality of care. And we want to make sure everyone feels supportive in how we can advance our tobacco interventions. Now, if you have people that use tobacco, I often will, even on a one-on-one conversation with them, just take them aside and, are you going to be okay with this? Do you need any special support to adjust and adapt to our new policy, or how you're going to facilitate this in some programming? If you have someone who uses tobacco, that may not be the ideal person to provide the tobacco awareness session in the clinic. You may want to find someone who does not use tobacco or is a former smoker to facilitate that. But all I'm suggesting is be very sensitive to the needs of those who use tobacco. Some people will be threatened by it. Some people might express anger. I find that those are more rare incidents than those who are just supportive and then use this as motivation to, well, I just won't smoke at work. We can't tell somebody what they should choose to do in their own personal life, but in terms of how we need to support our programming and our clinical interventions, we can have guidelines. I wouldn't want anybody, any therapist facilitating a group that had beer on his breath, and I wouldn't want anybody facilitating a group that had tobacco smoke on their breath. So we have to explain the rationale of how and why we need to have these types of staff policies. And if you need help, we can provide that with regard to some assistance to help you either cut back and reduce so you're comfortable at it while you're on the job, or if you want to use this as an opportunity to totally stop your tobacco use, we will support that as well. So I encourage that kind of very personal case-by-case contact with staff, and that message has to be very clear and upfront, because if you don't do it, there's underground activity that can undermine this. So if we're not being sensitive to that, you're going to again turn this into the smoker versus a non-smoker kind of a thing, and that's a climate that you don't want to create.
Great. Well, thank you very much, Tony. Just in the interest of time here, just a couple notes for some conclusion. There are going to be 2 emails that you'll get following today's webinar. One is going to contain the recording of this webinar and the slides. So you can be looking for that. That email will also have a link to help you register for the next webinar if you haven't already. The other email that you'll get will contain a link for the evaluation and the CEU form. And this has to be completed for us to be able to track and issue CEUs and certificates of attendance. So of course we appreciate everybody's feedback if you can fill out the evaluation, because it will help us to plan upcoming activities. So if you have any more questions, you see on the screen who you can contact in your state. Janelle if you're in Minnesota, Beth if you're in Iowa, Reba if you're in North Dakota, and Monique if you're in Indiana, and we'd love to follow up with you. So we'll be back in 2 weeks from today for webinar 2 on behavioral interventions, and that will have a focus on client engagement. Thanks so much for attending, and have a great day.